Good morning, everyone, and welcome to the Epilepsy Foundation of Connecticut webinar series. My name is Monica Anzalone, and I will be moderating today's webinar. For the purposes of sound quality, all of the participants have been put in listen-only mode, but we welcome you to use the chat icon on the bottom of your screen to type any questions, and these questions will be answered at the end of today's presentation. Today's webinar is on the psychosocial impact of epilepsy on children and will be presented by Dr. Vinita Knight and Dr. Paige Lembeck. Dr. Knight is a trained child neurologist and epileptologist at Yale New Haven Hospital Pediatric Neurology Specialty Clinics with an interest in caring for children with neurologic problems such as seizures, migraines, strokes, developmental delay, and movement disorders. Dr. Lembeck is a licensed pediatric psychologist and assistant clinical professor at the Yale Child Study Center. Specifically, Dr. Lembeck provides clinical services within the Yale Child Study Center's outpatient psychiatric clinic and within Yale New Haven Hospital's pediatric neurology specialty clinics. So we welcome Dr. Knight and Dr. Lembeck, and I will now hand it over to Dr. Lembeck to start us off.
Hi, everybody. Thank you so much for joining us today.
Yes.
Okay, so I want to first go over our key objectives for what we hope to accomplish during this presentation. Of course, we hope to make very clear that the relationship between epilepsy and mental health is quite strong. There's a strong mind-body connection in general that I'll discuss. What's important to note as well is there's a great variability in how people cope with epilepsy and what psychosocial functioning is like for this population. So even though there are, of course, risk factors, what you'll learn is that having epilepsy does not necessarily mean that you will do poorly from a psychological perspective. Providers can work as a team to promote a child's health and functioning, so that's another discussion point, and we'll also provide a couple resources that can help support families coping.
Hi, everybody. This is Dr. Knight. Thank you again for inviting us to give this lecture today. As you can imagine, you all know, love, and care for a variety of different children, but I wanted to sort of give us a frame of reference of a child that I might see day to day in clinic. Skyler is a very sweet 9-year-old third grader who started having seizures, particularly generalized convulsions, when she was 8 years old. Her first seizure happened at home. However, her second seizure happened while she was in school, and some of her classmates saw the seizure happen. The teacher did clear the classroom, but as a result of this, her personality has changed a bit. She's more shy, she's not as interactive with her classmates, and there's some school avoidance, meaning she tells mom and dad, oh, my tummy hurts, or do I have to go to school today? So this is very representative of something that parents talk to us about, and kids themselves. And one of the things we're hoping to address today is how can parents, family members, teachers, and us as providers help with this situation.
This is Dr. Lembeck again. As I mentioned earlier, chronic illness does not affect all patients and families equally. What you will learn and what I'll talk about is families who are affected by epilepsy can be very resilient. What resilient means is people cope very well in the face of adversity. So this begs the question, which factors actually promote resilience and adaptive coping? And that's something that I'll talk about a little later. As I just reviewed, there's a very strong relationship between physical and mental health. This is the case both for chronic illness and also just in day-to-day life. I like to give an example of an athlete playing on the field and injuring themselves in some way. It might be a cut, it might even be a small broken bone. Sometimes what we find is these people actually continue to perform very well and don't feel that pain until later. So this is one example of many for for how the mind and body can work together. So I have some families who are surprised to see psychology in a neurology clinic, but there's actually a very important place for psychology in dealing with these issues. And we'll certainly discuss this later in the context of non-epileptic seizures that could happen. So we do have a very flexible definition of stress when we think about stress. So I find that with working with families, sometimes that could be a reactive word of like, well, there's not much stress going on in our lives, but this could be something as simple as if there's a very busy schedule going on, or if there's a transition to a new school. So we're not necessarily thinking about trauma in the context of a medical condition or physical issues. We're just thinking about big changes or larger experiences. Also, what relates closely to the mind-body connection is the activation of the ANS, which is that fight or flight system in our body. This can sometimes, I almost think of it as misfiring. It can sometimes behave in a way that can result in pain and other somatic symptoms like stomach aches. So I'll talk more about that later. Okay. As we approach helping kids with epilepsy and other kids who have medical conditions, I like to think of it from something called the biopsychosocial model. This takes into account multiple factors, and it's a very comprehensive model for thinking about the whole child and not just the physical illness. So of course there's disease-related factors like the extent to which the epilepsy limits a child physically. There's always health complications that occur. The severity of the illness needs to be taken into account, and then other medical regimens that go with it. There's also intrapersonal factors. These are the individual level factors. So of course kids and adults are born with certain qualities, like a certain personality. Other individual factors are age and gender. And all of these things interact with the environment as well. So how much stigma there is, and then larger environments like schools and homes and communities. So this really speaks to the need for a holistic, comprehensive approach to care.
Switching gears slightly, as all of you are aware, either from discussions with your doctors, nurses, reading the web, or talking with friends and that also have children affected by epilepsy, you would know that a seizure is essentially a manifestation of excessive synchronous electrical discharge in the brain. So the term epilepsy is sort of a funny term and a scary term for many people. And I've often had families cry in my office when I explain that their child has epilepsy. Although there's a very long definition in the medical world, really what I think of epilepsy is as having two unprovoked seizures that are more than 24 hours apart. I will say that the vast majority of children that have epilepsy are quite normal, meaning if you were to see a child with epilepsy on the street, you are very unlikely to realize or to know that they have seizures. There are, of course, exceptions, and there are some children that look different physically that also have seizures. We do know that kids that have very high seizure burdens, daily seizures, uncontrolled seizures, may also have concomitant developmental delays. Going on to the point that we discussed already, as we said, most children with epilepsy are developmentally normal. Again and again, just sort of repeating the same point again. Developmental progress, as you can imagine, is very relative. Kids, as we all know, walk at different times or start talking at different times, and we expect this. You know, even within the same family, a set of siblings or even sets of twins might develop at different rates. We also know that kids that have intellectual disabilities or cerebral palsy can also have a very variable course of developmental gain. The big thing that I stress with all my patients is providing them the support they need to progress at their own rate. There are, of course, some rare degenerative neurologic conditions, things like Rett syndrome or other syndromes, where rather than progressing, children learn something, perhaps learn some words, and do lose those milestones. But again, this is the minority of cases, and your team will provide tailored counseling for those cases. Another point that I wanted to mention is that children that do have recurrent seizures or epilepsy might have a very prolonged seizure, something called status epilepticus, that typically requires hospitalization and medications. And sometimes these children temporarily lose skills or things that they have learned.
I'd like to touch on some of the common challenges that can come up for children with epilepsy. Unfortunately, and I want to make the point that these are correlates. It's not necessarily that epilepsy directly causes these things. They just tend to be more likely. Unfortunately, sometimes kids with epilepsy have externalizing difficulties. These would be more of the behavioral difficulties that you could see with your naked eye, like increased aggression and ADHD symptoms. Sometimes they actually meet criteria for a diagnosis of ADHD. This is quite common in this population. Because epilepsy involves your brain, they are at higher risk for cognitive and learning difficulties. As Dr. Knight mentioned earlier, school avoidance is a factor that comes up pretty regularly. A lot of the times it is because children are afraid of having a seizure at school and what would happen if that occurs. And I'll talk more about how that can become a vicious cycle later in the presentation. Internalizing symptoms and emotional dysregulation are also more likely. What emotional dysregulation is referring to is the idea that somebody could have more difficulty controlling their emotions. Of course, we're all human, we're not robots, we're gonna have difficult feelings at times. It's when these feelings are really out of control and impair a child's functioning, that's when we start to call it emotional dysregulation. Children with epilepsy are at risk for social problems and peer victimization or bullying. Just to make a note about bullying, there's actually a definition of bullying that most people are not aware of.
I wasn't aware of that.
Yes. And this is something, it's defined as bullying when 3 factors are in place. So it does need to be an instance of aggression in some way. Importantly, it needs to be repeated. So if it happens just one time, that would not meet criteria for bullying. And there needs to be a power imbalance. And that power imbalance could happen in a bunch of ways. Sometimes a child is smaller than another child. Sometimes it means a kid is less intelligent or less popular, so there's different types of power. In the case of epilepsy, it could be bullying when a child is ill and has epilepsy compared to a healthy child. So just, I wanted to make a quick note of that. And then another important challenge that I'll talk about later is increased somatic symptoms. The term somatic means any kind of bodily reaction that's not necessarily due to a medically diagnosed disease. So this could be something like having stomach aches, chronic pain when we can't find a diagnosis tied to that, your heart racing really fast, sweating a lot, dizziness, all of these body reactions. And then we'll talk about PNAS later on.
There is a term in the medical community called adherence. And what we mean is, are you taking your medicine the way that it's prescribed? There are so many reasons for children with epilepsy to not take their medicine. There can be many times where their medications don't make them feel well. They have side effects. Perhaps they have noticed some changes in how they look. For example, Depakote is a common medicine that we use, and sometimes that can result in some weight gain or some loss of hair. Sometimes kids will have been taking medicines for 2 years and haven't had a seizure, so they wonder, why am I taking this? Sometimes there's simple barriers. We forget to take our medicine. I know I've certainly done that myself. Sometimes there's insurance issues, pharmacy issues, or we've traveled to Hawaii and we forgot to bring, pack our medicine. All different types of barriers. And I know we here at Yale really try to work with our families to find out if the children are taking the medicine, and if there is a problem, is the 3-year-old spitting the medicine out because it doesn't taste good? We all really want to work with families to provide either an alternative, a liquid formulation or a sprinkle formulation, something that works, that both minimizes side effects and minimizes seizures. And of course, we do strive to address these problems in a developmentally sensitive way. So if I have a 16-year-old who wants to drive a motor vehicle, how I might talk to them about their need to take medications is going to be quite different than a 5-year-old who is running away from mom every time she's pulling out the Keppra to give to the child.
And just to piggyback on what Dr. Knight was saying, and in my experience in working at Yale and in other hospitals, I think a common issue that comes up is parents are very motivated to have their children, especially their preteens and their teenagers, take responsibility, complete responsibility for their medication regimen. And sometimes that's appropriate and kids are motivated, but other times parents need to continue to provide that support, even if it's an age that they don't feel like they need to be doing that. So I just wanted to make that plug that these are things that are great to talk about with your medical team. And then if there is a mental health provider involved, they often problem solve around these things.
Thanks for adding that.
I'd like to switch gears to talking about PNAS, or psychogenic non-epileptic seizures. This is extremely common in kids who have been diagnosed with epilepsy. So that's the term comorbid there. It just means it's co-occurring a lot of the time. PNAS tends to be more common in situations where there's chronic stressors. And again, cycling back to what I mentioned earlier, this doesn't always necessarily mean a major trauma. It can sometimes just be conflict within the family or some of the other changes I mentioned. It's also more common in kids who kind of have an internalizing or avoidant coping style. That doesn't mean it can't happen in kids with more behavior problems. It just means that the kids who kind of are very good at hiding their feelings and keep everything inside, sometimes it has to come out somehow. So it could come out as something that looks like a seizure. And it's also similar to what I said before, co-occurring with anxiety and then somatic symptoms of other types. What I like to make extremely clear when I work with families where this is happening is that this is not something that's done on purpose. It's not that a child is doing it consciously for attention. I can't stress that enough. I think sometimes what happens is it will be something that looks like a seizure, that looks almost identical to a seizure, and then a child will go through an extensive medical workup, and then parents are understandably very upset when the psychologist gets called in. And really, it's not a message that this is fake. It's an extremely real symptom that can happen, and it's very complex. So let me continue on to tell you a little bit more about that. Just to give you a little more information, there is a higher incidence of this happening in pre-adolescence and adolescence. Tends to occur a little more commonly in girls than boys. I wanted to mention a couple red flags for this that would differentiate it from an epileptic seizure. The symptoms tend to sometimes not be biologically plausible. For example, and Dr. Knight, please correct me if I'm wrong, but usually during the postictal period, kids take a little while to reorient. So one example is for kids with PNAS, it could be that it's almost like they rapidly come to and are able to almost behave completely normally very, very shortly after that. And then another instance could be that functioning is not consistent with the degree or severity of the symptoms that are there. So there's many more that I could list. I think keeping in mind if you know what your child looks like and you're working with your team and you have a typical idea of what their postictal period looks like when they're having a quote unquote true seizure, if there's major differences between that, for some of these things I just mentioned, then that's kind of a red flag that maybe it's these as well. Broadly, the intervention for helping with PNAS is promoting a child's typical functioning as much as you can. There's often multidisciplinary rehab that takes place, and then importantly, attending to the adaptive behaviors. So that's keeping a child on a schedule, keeping them going to school, keeping the behavioral expectations you would have in place at home, like chores. Really pushing for that typical functioning is vital to help manage these. Given all of these factors that we've talked about, and simply having a diagnosis of epilepsy in and of itself speaks to the need for intervention. And I think what I like to say is yes, I love this slide and this comic, but anybody would need additional support through this. Unfortunately, there's a lot of stigma behind mental health treatment, but there's a very valid case for it in these situations. I want to switch a little and talk about the factors that are associated with positive adjustment. Those are just as important to know about. As I mentioned earlier, resilience is resistance to adversity. There are individual components of resilience and also social components of resilience. It's very helpful for families to just gain as much knowledge as they can about epilepsy. This helps increase families and really kids' sense of agency, helps people build confidence and more self-esteem. It's kind of like knowledge is power, and it helps these people move forward and do better. And this is in the context of knowing that having a medical illness can really threaten somebody's sense of control. There's a lot of things that kids with epilepsy don't feel like they have control over, like the need to take medicine every day and will I have a seizure today? I mean, those are things that are scary to deal with. And then, of course, and I'll talk more about this, but parents' coping is strongly correlated to children's coping. So if parents aren't doing well, kids will struggle, and then the same goes for the positive alternate of that. I think I hit on this point already, but epilepsy itself doesn't necessarily mean difficulties will occur. It can sometimes be correlated with negative self-concept, but not always. And in fact, there's some research to show that it's not always associated with maladjustment. Youth with an epilepsy diagnosis should still be encouraged to do the same things that other kids should be encouraged to do, like go to school, do sports, extracurriculars. Of course, sometimes there's limitations, but for the most part, they can be normal kids.
So along the same lines that Dr. Lembeck was talking about, I feel strongly that kids with epilepsy, and even kids without epilepsy, such as siblings, can certainly learn and understand the basics of seizures. I often try to frame it in ways that children can understand, such as, again, an electrical storm in the brain that might cause the body to shake or move or stare or whatever the manifestation be in that particular child. I apologize, the next bullet contains a tiny bit of jargon, but I do feel strongly that if possible, it's really important for kids to know the name of their medication. It's helpful if they can kind of know a little bit about the color, what it looks like, and even if possible, the dose that they take. all of us absolutely love and care for our children, but occasionally they are out of our care, whether they be with a relative or at school. And so if something happens and they have this information on hand, it can be very helpful to any providers that might need to provide care for them. We had talked about the importance of medication taking before, in a few slides ago, but again, just that it's very important to take medicine every day, even if the child hasn't had seizures for a while. Let's see.
There we go.
Yeah.
Okay. I'm looking at our time. I'm just gonna pick it up a little bit, but as I mentioned before, family definitely impacts a child's coping with this. Kids exist within families. There's oftentimes with serious medical conditions, a lot of uncertainty about what to communicate to children at what points. This causes and contributes to a lot of caregiver burden and anxiety for parents as well. There's this concept called mutual pretense, and what that means, to just explain it quickly, is that there's worries that parents hold and worries that kids hold about what their illness means and what will happen to them, and prognosis and all of these deeper questions, if you will. And mutual pretense occurs when parents and kids hide those worries from each other. So there's not open communication when open communication is really the goal. There's also a concept called parental accommodation. What this means is allowing more room for anxiety. And it's actually a negative term in the context of anxiety. So for instance, if a child does not want to go to school and a parent says, cool, like you're feeling sick today, you don't have to go, that's accommodating the anxiety. And over time, that can create a cycle of anxiety becoming worse, and school avoidance becoming worse. So we do a lot of work here at Yale to target parents' behavior and to help parents know when to set appropriate limits so that it actually has a nice effect on reducing children's anxiety.
Along those same lines, there is a very difficult balance that each family strikes up between caring and caution for their child with chronic illness, and letting the child learn and grow and participate in sports. We see this clearly in epilepsy and neurologic disease, but even, with cystic fibrosis or cancer, where family have this sort of overprotectiveness or want to reward their child. Even though this terrible, horrible thing is there, the child should not get to eat ice cream for dinner every day, because that's not healthy either. In general, most children need to eventually learn to become independent from their parents and live their own lives, and live potentially, some of them, with epilepsy into adulthood. And so we need to support both the children and the families and parents into this role. We do have other instances of children that may have significant cognitive impairments who may not be able to live independently. And we help find residential or some assisted programs for these children or young adults. We here at Yale actually have a formal transition clinic which particularly specializes in this type of population.
So because of the things that we talked about, it is very common to avoid some of these difficult conversations around epilepsy. I mean, that's just normal human reaction of that thing's hard to do, so I'd rather not. There are some consequences of secrecy in general. I think if families keep very big secrets about very big things, it can cause a lot of family dysfunction. It can increase anxiety. So that's why I bring it up in this presentation. There's I like to remind families of, even though it comes from a very good place to not share certain information with your child, and it comes from a place of wanting to protect them, sometimes this causes kids to create more fears, because it's almost worse to have a fear of the unknown about what's going to happen and what's to be expected, more than it is to know the reality, even though the reality isn't very nice. So an example of this is, this is a very small scale example of telling a kid like, oh, that medicine's going to taste great, when it's not. Yeah, it's not fun to say this won't taste that good, but that better prepares a child. Again, that's a really minor example. Another thing that happens in this population and populations of kids with any medical condition is, all kids are on the internet now. They want to Google, what they have.
And parents.
Yes. So I can't stress enough, and I'm 100% that Dr. Knight would say the same thing. Please communicate with your medical team and encourage your child to do so. Yes, it's frightening what's on the internet. I don't have to convince you all of that. And then, as I said before, thinking developmentally about this, what you would tell a 3-year-old is much different than what you would tell a 16-year-old. I'm going to talk about something called behavioral activation. Anybody could use this. It's not specific for people with epilepsy. It is just the concept that if you are feeling down and struggling, step 1 is to keep a normal routine and to do things you enjoy. I mean, it's so intuitive that if you do things that make you happy and are pleasant activities, you're going to feel better. The same is the case for kids with epilepsy. So the little comic that I won't read to you is basically depicting sometimes we get sucked into that dark place and it's hard to get out of it. So at first your child might resist and say, you know what, I don't feel like getting out of bed. I don't feel like going outside. That's your moment to push and to encourage them. Let's fake it. And you used to like doing this. Let's try it again. And that's what will help in the long run with mood.
So along the same lines that Dr. Lembeck has been talking about, I can't stress enough how important it is for kids with epilepsies to relate, to play, to have the bickering, the normal childhood things, and to share and grow together. And I really push that kids with seizures be included, play sports, play on the playground. I know that they may fall on the monkey bars, but that risk is low compared to the importance of growing as normally as possible. With special precautions and close supervision, I think that most activities can be safe. For example, swimming in the context of an adult being nearby should a seizure occur in the water. That being said, our team of child life specialists, psychologists, and social workers certainly can help find activities either after school or sports or summer camps to really engage our kids. I really like this quote. Let me read it here. Initially, Jim and I were so consumed by Anthony's epilepsy that nothing else seemed to matter. Between the seizures, the meds, the doctor visits, tests, meeting with teachers, and our jobs, there was no time for anything else. It took us a few months, but we finally realized that life goes on for Anthony and his little sister.
Just to, as Dr. Knight was reading that, so this is a little side note, but before this I worked at St. Jude, so there was a lot of kids with catastrophic illnesses of different kinds, and what I think her quote points out so nicely is that resilience that can happen in families. You know, it's amazing. You would see these kids come in with cancer and people's minds would be spinning and all these fears would be going through their heads the same way that would happen for a family who just received an epilepsy diagnosis. It does become a part of normal life in a lot of situations. So thank you for sharing that quote. I just wanted to share briefly about how our model of care works for my involvement as part of the multidisciplinary team. My role is to consult with neurologists and other medical, rehab, and psychosocial providers like social work and child life. My role that I'll talk about in a little more depth soon is to assess, of course, the emotional, behavioral, social, and adaptive functioning of kids. So we do some proactive screening. And then we do targeted intervention and referral. So unlike a common psychology clinic where I would see a child week after week for months at a time, this is just to be more brief intervention. So I'm sharing this with you not because it's the case everywhere you go, but it is one example of how this could look. I think in general, psychology is becoming more integrated in medical settings. I would not be surprised if many of you go to your pediatrician and there's a psychologist or at least some kind of psychological screener being given for you to fill out, you know, is your kid feeling depressed lately? So I think the world is moving this way. So that raises the question of when is it appropriate to really seek a psychologist or some kind of mental health professional for your child? The number one question that we're always thinking about on our end is functioning impaired. So are the symptoms of anxiety or whatever it is getting in the way of your child's life or your family's life in some way? Is it affecting their relationships? Are they starting to do more poorly in school? Is it affecting home life? So if it's getting in the way of something, then it's time to seek additional help. Of course, if it's affecting medical care, that's a great time to do so. If there's concerns regarding safety of any kind, one example is suicidal ideation, and then family stress. That's sometimes it's the case that I'll just meet with parents and the kid is doing well. So I would really think about these things. What can psychology provide? This is just a smattering. There's more examples than this. It's not an exhaustive list. Many of them I talked about already, and there's others I didn't go into yet. What psychoeducation means, because I think that's a term that's not familiar to everyone, is basically just education about why things are happening psychologically. It's kind of more of a teaching model. It's giving away our knowledge of psychology and giving it to families. You know, behavior management, that's usually in the context of these more disruptive behaviors like aggression and ADHD symptoms. And then the other ones I think are pretty self-explanatory.
So there are many different resources around the topics that we've discussed. I really like the Orrin Devinsky book and of course the Epilepsy Foundation. And of course, feel free to always talk with your providers about other references that might be more specific for you and your situation. We hope today that we've covered some good ground. As we have pointed out again and again, kids with any type of chronic illness may be at higher risk of experiencing psychologic difficulties that can vary quite a bit in how they look. We here at Yale and at many institutions across the country feel that it's really important to integrate psychology, social work, child life, nursing, just having a really good rounded approach, because we're not just treating the child's brain, we're treating the whole child. And so, you know, I never want a family to think that I think they're crazy and I'm bringing in a shrink. This is really part of our model for the best care possible for kids. As Dr. Lembeck has pointed out, there are a lot of different factors that are associated with resilience, including communication, helping kids be independent, and being integrated into their communities and their school world.
And as a final note, I'd like to point out that, I always have kind of a funny thought in my head as I do this, that really a major factor that promotes resilience is getting hooked into the community that you're affected by. So the fact that you're taking a first step by, or maybe not a first step, but you're doing this webinar and you're participating, that is already associated with resilience, seeking that social support from professionals and other families who are affected by the same thing. It's really the people who are not on the webinar that we would love to be talking to as well, which is always kind of a funny thought in my head. But thank you so much for hearing us today and for listening. And we would love to take some questions if now's a good time.
And absolutely, at any point, feel free to reach out to either Dr. Lembeck or myself. We both accept new patients, and beyond just us, the Yale is accepting plenty of new patients. So if we can be of assistance, we're here.
Yes, agreed.
Thank you. So we will take some questions. Please type them in the chat section on the bottom. If you can see the little bubble there, you can type them. We'll take a few minutes for questions. And I am not a caregiver, but I definitely feel empowered by that webinar. A lot of good information, and certainly made you want to move forward, although this can be a very difficult diagnosis to manage. So I really appreciated all of that. And I'm sure that for people that will be listening to the recording will find it beneficial as well.
Thanks, Monica.
Thank
Sure.
you.
And while we're waiting, if people do have questions that they're typing in, I do have one question, doctors, regarding, you mentioned a transition clinic there at Yale, which I didn't realize you had. Is there an age bracket for that?
That's a good question. I think it's one of my partners, Dr. Farouk, that manages that clinic. I think we tend to refer over 16 or 17 for that clinic.
And is that only for housing, or is it just transition?
Nope. I apologize. It's for more issues than that. There are many issues facing kids as they sort of leave the pediatric world, whether it be moving on to college or independent living or driving, any of those resources. I personally, in my practice, tend to use that clinic a little bit more for the more impaired kids, but that does exist as a resource for us.
Okay.
So for the families who aren't familiar, and I apologize if this is information you already know, but more and more transition clinics are coming up because I think a lot of medical providers are, there's people who specialize in pediatrics and there's people who specialize in the adult world, and there's not a great place for helping kids with that transition. So these are created very intentionally to help kids and families be ready for that transition to adult care. And it also helps kids take on more of their own medical care, I would say.
When I think about my teenage population, I have some 15, 16, 17-year-old kids that want to kick mom and dad out of the office visit and want to talk to me about their meds, what's going on with their seizures. And then I have others that, that they don't want to leave. I have 22 and 23-year-olds that I love taking care of all the kids, but, sometimes they start to have issues that I don't deal with every day, blood pressure issues, or they're pregnant themselves. And I feel that my adult colleagues are better equipped to take care of them. And so I try to gently help them bridge that gap. The feel of adult providers can certainly be a little bit different. There may not be a train in the waiting room, but, this is a transition that young people do need to make at some point.
Very good. And just to, for those listening, as far as supports that we can offer here at the foundation, there's a section on social engagement and support. which is so important. We do have a summer camp here in Connecticut for kids up to age 20, I believe. And then we're also starting a Studio E art therapy program for those interested for teenagers.
Oh, that's awesome. Can you send me some info on that? The Studio E? Okay.
Yeah, absolutely. And we are still accepting some people. So we have some spots open.
That's fabulous.
And it looks like we do have one question here that I'll read, doctors, and it says, how do I convince my sister to seek mental health? She has no interest in social interaction.
That's such, this is Dr. Lembeck. I can't tell you how often this comes up. I think, and I really wish I had an easy answer. I wish I could give you a formula for how to do that. I know how difficult it can be to be in a position where you're seeing somebody suffering and you're seeing the need, and they're just not willing to go. I would say, and you know, this is also tough because I don't know that family member. We often think of how to give advice and how to help people from an individual perspective of, you know, what will work for that person. If I would consider, and again, this is not going to solve it, but I would consider who is close to that person or who would be able to get that message through. It sounds like you're doing all the right things by being concerned and trying to voice those concerns. There are times that even when we get people through the door to our clinic and they're sitting in session, some people just are not ready. And I just want to give you reassurance that because this person isn't ready now, doesn't mean that they'll never be ready. I think continuing to provide a space for that person to come to you with concerns that they have, that's a great thing that you're already doing. I think if this person's an adult, then there's not much that you can do to mandate them to go. That's the unfortunate reality. But you can be there and show your concern like you already are. I'm sorry that you're in that place.
Okay. Well, it looks like if we don't have any other questions, we'll go ahead and close out. I know everyone's time is valuable, and just as a reminder, this has been recorded and will be available soon on our website for future reference. And again, I just want to thank Drs. Knight and Lembeck for their time and for this great presentation. And on behalf of the staff here at the Epilepsy Foundation of Connecticut, I thank everyone for joining us and taking the time to participate in today's webinar. Thank you.
Thanks for having us.
Thanks for having us.
Bye.
Bye.